Information contained in this event represents the personal views and scientific medical opinions of the speakers and does not necessarily represent the view or opinion of Corsim. This event has been made available for informational and educational purposes only. Corsim does not make any representation or warranties with respect to the accuracy, applicability, claims, or completeness of the event. The topics discussed in this event may not be aligned with the labeling approved in your geography. Please consult your local labeling. By participating in this event, attendees consent to the recording of audio, video, and any other materials exchanged or presented during the event. It is acknowledged that these recordings may be used for future purposes, including but not limited to distribution, publication, or promotional activities related to the content presented in this event. Attendees who do not wish to be recorded are kindly asked to refrain from active participation.
Great. Welcome, everybody. I'm Vino Thrani, cardiac surgeon in Piedmont Heart Institute in Atlanta, Georgia. And I have the distinct pleasure of moderating a session that I think has become more and more important globally, not just in the United States or in Europe, but really globally. And we have a phenomenal cast of characters that are going to discuss really what lifetime management aortic valve disease really means. And I think this is a really important topic. And I think that we're going to have a lot of fun with this. Danny Ramsey is also on as Bart Miras and also Farouk Oeda. And we're going to get started so that we have plenty of time for questions. I do want to mention for the webinar, there are, for the Zoom calls, as most of us know now, there are chats and there are Q&As, and we'll monitor those also just in case you have questions throughout, and hopefully we'll leave plenty of time for some type of discussion. So welcome, Farouk, Bart, and Danny, and maybe I'll start off with balancing between transcatheter and SAVR, and what are some of the immediate outcomes and lifetime durability. All right, let me share my talk. So I think that this has become one of the largest, for my valve clinic on Monday that I do with our cardiologists, this is really an important aspect that we discuss, how we balance the lifetime durability for patients. And it's interesting for me, in my practice over the last 5 years, I've put in more mechanical valves than I have ever before, partly in my 20-year career. Partly because we're dealing with lifetime management. A lot of the patients we're getting are in their 40s, 50s, and 60s, and we really want to give them a one-shot deal. And my cardiologists are very supportive of this. And today what we'll do is we'll discuss some of the other TAVR components that are important as we look at long-term data. These are my disclosures. It's interesting, the management of aortic stenosis has never seen so much play within the New England Journal of Medicine. And we've had one paper in the New England Journal of Medicine for the last 9 years, mainly from the Edwards and the Medtronic camps for TAVR, comparing TAVR to surgery. And that's really brought a lot of light to the management of aortic stenosis. And as you can see here, we have over 9,000 patients that have gone through randomized core lab adjudicated trials. And this is kind of the culmination of that. And of those, 4,000 were patients that had a surgical valve replacement. So a lot of data on surgical valve replacements across the board. So 12 years of trials, 9 trials, over 9,000 patients. And of these 9,000 patients, about 8,000 were randomized patients. And when we look at the guidelines, at least the US guidelines, you see that it's very complex, but those patients under 50 are recommended for mechanical valves. Those between 50 and 70 have a shared decision, and those over 70 have tissue valves. And in the US guidelines, if those patients have tissue valves and those under 65 should really be heading towards surgery, and those over 80 should be heading towards TAVR. And then, of course, in the middle would be shared decisions. And for me, the way I look at it, it's not really under 50 for mechanical valve. Personally, I recommend everybody under 60 to, sometimes a very healthy 62-year-old who's going to live for 30 years towards mechanical valves. And that's been an important shift in my practice over the last 5 years or so. The European guidelines are very similar, except that they have really under the age of 75 should be heading for surgery, not 65. The new European guidelines are underway, so it'll be interesting to see how that materializes. There's also a team now being put together for the US guidelines, valve guidelines. Again, that'll be very interesting to see how that plays out. There's some key caveats that all these randomized trials that I just spoke to you about had a lot of exclusion criteria that we don't necessarily hone in on. And those are some of the different ranges of annulus. The bicuspid valve is the most important, probably. Severe aortic regurgitation, those with LV dysfunction, less than 25%. Severe calcification of the aortic valve complex. If there was a lot of calcium in that aortic valve, they were deemed not to be able to be randomized. And of course, for surgeons, we deal with that all the time, so it's not very unusual for us. Of course, CAD, those with low coronaries and vascular anatomy, that's not suitable. And at the end of the day, this is data that was published, and I'll show you data between the Evolut valve, and I'll show you data for also the partner studies back and forth. As you can see here, all-cause mortality and disabling stroke was about 14% in surgery and about 10, almost 11% for catheter valves. This is at 4 years. The more recent data has come out now recently on the 5-year data for this. And so here you can see this was just published in JACC of 2025, and where they show that that gap, remember I just showed you 4 years, there was a much bigger gap between the two, and all of a sudden in 5 years you really see things coming together. And if you remember the numbers, it's approaching 15% for the TAVR and 16% for surgery. I think these numbers are important to remember. 15, around 16% for all-cause mortality and disabling stroke. Now, the primary endpoints are very different between the two. For the partner study at 5 years, you see is death, stroke, and rehospitalization. I'll break it down for you in a little bit. And so when you put all three together, you can see that surgery has about 27%, and you see that TAVR has 23% for these. Now, when we look at just mortality across the board, you see that the majority of the driver at 5 years was mortality for the Evolut trial. You can see that mortality at 5 years for the surgery arm is about 15%. And you can see that mortality for TAVR was about 14%. So remember those numbers, about 15% for surgery, about 14% for TAVR. Now, when you look at a partner study, the mortalities for both are much less. Instead of a 15% mortality, now you see surgery with a 9% mortality, which is a much different mortality curve. And you can see for TAVR, it's about 10% with a crossover around 3 years. I don't necessarily look at the lines as much as I look at the end result. The end result is surgery with a 9%. And you can see, I think it'll be interesting to see as we carry this study out what happens. Does the TAVR continue to have issues, or does it not? Does surgery remain strong, or does it also have issues? And you can see the slope is increasing after 3 years for transcatheter valve. And if you look at for TAVR in the blue line, you see that slope after 3 years also increases pretty rapidly for that. When you look at overall valve performance, what we see for TAVR and surgery is TAVR slightly better, about, quite honestly, on the mean gradients, about 2 millimeters more better, I guess, with TAVR. And surgery is about 12.8, and at 5 years, and you can see TAVR is around 11. When you look at hemodynamics for the SAPIEN valve trial, you can see about 11.7 for surgery, and you can see about 12.8. So the way I think about it is that a gradient is about 2 to 3 millimeters more with the SAPIEN valve, but you can see that we have great results with surgery at 5 years also. Recently, we published a paper from the STS, which looked at 42,000 patients, which really is the largest study looking at low-risk patients, and we mirrored them to the PARTNER 3 and the Evolut inclusion-exclusion criteria. And at the end of the day, what we were seeing is that the average age was 74, very similar to the partner in the Evolute studies. And the predicted risk of mortality was 1.9%, very similar to the partner in Evolute studies. And we showed something that was very comparable to the partner study, as such that at 5 years, what you're able to see is really good numbers. We're seeing patients that have 96% survival if their STS is less than 1%, like most of our patients are. So really good numbers when we look at those patients that are about 95% 5-year survival. Again, similar to the SAPIEN, the Partner 3 study outcomes, much lower than the Evolute study outcomes that we saw of 10 to 15%. I think it's important that there are some concerns with bicuspid. There's talks of a lot of trials in this, but right now, I think we have to be careful with this component of it. There's a lot of reasons that there's TAVR concerns, and we have to really be cognizant of how we deal with this. I think the explants can be somewhat difficult. Here you can see a SAPIEN valve, a patient of mine where I'm having to carve this out and really be meticulous in my dissection for removal of SAVR explants. This again is a SAPIEN, and on the next one is a core valve. You can see that the core valve is much higher up, and so you have to deal with a lot of this higher up, close to the SCJ, where in the SAPIEN valve, you're dealing a lot more lower down at the annulus level. So they both have positives and negatives on how to resect these, and this is usually my technique, is with a 15-blade knife and removing these. Overall, the results are about 30-day results for TAVR explant is about 10 to 13%. My personal series is much better than that, but this just represents the countries and the US data for this. There has been a lot of push towards TAVR and TAVR. This is not easy. It's very complex. Recently, we did a patient that needed a shortcut and bi-basilica, and here you can see we have wires in the left main and we have wires in the right main just to facilitate this, and these require double stenting after we deploy the valve. Redo TAVR also has its own issues with sinus sequestration. It's a little bit higher in the self-expanding valves than it is in the lower, smaller framed, shorter balloon expandable valves, but commonly it's in both of these. There's a lot of unknowns in TAV and TAV, so I don't think we can always promise our patients that TAV and TAV will be the panacea for this. And I think we really have to think about what is our 5-year, what is our 15-year, and our 25 years. I think this really becomes important, especially for those patients under 65, where a lot of patients of mine are now just choosing mechanical valves across the board. So maybe I'll stop here, and this gives us a little overview of the randomized trials in TAVR and SAVR, and I think that those have become very important across the board for us as we discuss kind of the future of it. Like I said, I'm been putting a lot of mechanical valves these days. I think this is something to be thinking about also for these patients. So maybe I'll stop here and we'll rotate to Danny Ramsey, who is going to talk to us a little bit about beyond TAVI. What are the strategies and challenges in TAVR explantation? Danny, you want to take it away?
Yes, thank you. Are you able to see the screen well?
Oh, that's perfect, Danny. Thank you.
Perfect, thank you. Well, you all heard about a little bit of overview there, and you saw a little bit on TAVR explant, and I was going to focus here on strategies and challenges with TAVR explants in this presentation. And this is really a challenge and something that we need to get on board of and mastery of. As you could see here in the data, there's increased use of TAVR implantation and use of TAVR in patients younger than 60. And we all see this. We all see this data where the massive proliferation of TAVR implants going on. When you look here at Vizient data, about almost 50%, 48% of patients receiving TAVRs are younger than 65. So we know we'll be seeing these patients with TAVR failures in the future. So what is our next step? You heard the challenges with TAVR and TAVR. Now we'll discuss a little bit more on TAVR explant and SAVR post-TAVR. There's significant risks, including risk for concomitant aortic surgery, a root replacement or root reconstruction, and other issues. First and foremost, mortality, as you've seen in the previous talk, is higher with the TAVR explant, SAVR post-TAVR. And it's not just operatively, as you can see, if you follow these patients, the mortality is still there, higher mortality in this patient group. The frequency is increasing. It's the largest and most rapid diagnosis indication for surgery in the SDS database, with approximately 14% mortality. So this is a challenge due to procedural complexity. The frame gets endothelialized, the aorta could be thin, the frame could be a little bit low and on the mitral valve. The median experience of patients, of surgeons doing this procedure is 1. And per institution is 1 when you look at the data between 2011 2018. We're gaining more and more experience, but it's still low in most surgeons' hands and in most institutions. It's more complex than just a SAVR. Of course, a lot of patients require concomitant root replacement, ascending replacement, root ascending, or mitral surgery as well. And of course, these operations have usually longer cross-clamp time, even when they go well. I discussed this a little bit, but things that can happen and complications that can occur and increase the complexity of the operation. We all know that the root may need to be replaced, as the root may be destroyed or injured. The membranous septum, which I didn't mention earlier, the possibility of injury and of creation of a VSD. The anterior leaflet of the mitral valve, as well as the aorta, could be completely destroyed, requiring ascending replacement. Several studies and more recent studies, the mortality is still significant at 30 days. This is not a de novo SAVR. A lot of this is increased cross-clamp time, technique, and surgeons' experience. So we'll look here at TAVR explant of a self-expanding valve, and this is sort of the roll technique. Initially, and this is a wire cutter that will cut the frame. You get a plane right in front of the endothelium. Ensure you don't get into the aorta, which is done at the ascending level or at the STJ level, which just cut the top of the strut out. Is it absolutely necessary? No, but it makes the roll technique easier if you're going to use this technique on a self-expanding valve. The next thing you do is on the non-coronary sinus side, in order to, and we'd use that area because if it's injured, it's easier to repair. Put a patch or use a graft to repair versus injuring the aorta at the coronary, at the left and right sinus where it's close to the coronary. So then we cut the frame all the way across. Once done, you grab each side. Here we're using ice. This is nitinol. We'll try to get the frame to shrink down. How much benefit does it do per case is very variable, but the technique involves now rolling the edge of the TAVR valve, and as you can see, it's completely shrunk down and it comes out. Some are harder than others. You still will have to dissect between the aortic valve, the native aortic valve and the TAVR valve, as you saw in the previous presentation at some points. So this is a TAVR explant using the 2 Coker techniques, similar to what you saw briefly in the previous video. You develop the plane between the TAVR and the native aortic leaflets, and while doing so, using 2 Cokers to crimp the valve to either Z it or just bring it towards the center, and then the valve comes out. Of course, this could be easier said than done, but it can facilitate removal by crimping the valve towards the center. So this is the roll technique now in a sapien valve. We use the similar technique in terms of self-expanding valve. We try to cut down on the non-sinus, as I said, and we try to split into the TAVR commissural area to split the valve in half. And we go all the way across. Then we grab both sides, and as you're going to see here, we will roll it onto itself. As we're doing that, it's lifting it off the native valve. Great care to make sure we're not injuring the aorta. We'll use an elevator or a 15 blade to separate it, or a scissor to separate it off the native valve. Now, if you could see enough of the native valve and you could roll it enough, you could actually just resect the leaflet, and the TAVR valve will slowly come off the annulus here, as you could see. Now, this is a great case when this happens, where you could just use a scissors and start cutting the leaflet out, and the valve will come out as you're continuously rolling. As you see, the valve is shrunk, so it gives you a plane to be able to do so. Finally, this is a tourniquet technique. You pass a heavy suture, silk or a proline, in and out of all the interstices, 360 degrees. And you may need to use more than one, but one usually works. Bring it in, and you remel this quite tightly to shrink the valve down, to bring the frame in, and then using a 15 blade or an elevator or a METS, depending on how much of the aortic valve leaflet you see. Usually a 15 blade is necessary. You don't always get lucky to be able to use the METS and be able to carve out and cut out the native aortic valve. What all these techniques have in common is you want to shrink the TAVR valve, so you expose more of the native valve. So when you're dissecting, cutting, or using a knife, that you're cutting on the aortic valve leaflet and not very close to the aorta or the root membranous septum, for example. And you could do the same technique with a self-expanding valve. Of course, the real issue with this is its higher mortality. Mortality is significantly higher. You could see here, 13.2%, 1-year mortality, 22. And this is, you see, this is not just one study, not in one database. This is data that we see in several studies, several database mortalities. And I bring this study here from Michigan, but you have to pay attention. This is from 2012 to 2019 with a 20% operative mortality. I will come back to that and show how we could, when we standardize our technique and get better with our technique, we can make an impact. When looking at the EXPAND registry, 13.1% mortality. And this is in a significant number of patients and centers. So this data is the data. This is how it looks like and when you look at other registries. Again, this is seen over and over again with a higher, not only hospital mortality, but up to 1-year mortality. This is significant difference. When we exclude when you look at conditional mortality after 1 month, you can see there's no difference between the groups here. Therefore, we have to do better. If we end up trying to perform better, standardize and reduce this mortality, we'll have better outcomes with our TAVR explants. So we need to standardize our technique, understand the techniques available in order to improve outcomes. And when we now look at the Michigan experience in their recent data, 2022 and to 2024, you could see an operative mortality of 5.6%. So this mortality will demonstrate longer survival and better outcomes for our patients compared to redo TAVR and TAVR, or then just leaving the patients alone, of course. This is a rapidly increasing diagnosis, and if you look at the data in terms of redo aortic valve replacement with prior TAVR here in this study, again, we could improve mortality, but SAVR versus TAVR, SAVR after TAVR, it still has a higher mortality than SAVR after SAVR. So we need to get better at what we do. And also, this also tells us that we need to also be better in our heart team discussion in which valves we implant initially. So maybe we should really focus on our patients that are, the ages of 55, 65, in terms of offering SAVR, Ross's, or mechanical valve, and trying to improve our results of TAVR explant, SAVR post-TAVR. So I would say that we are now in our second phase, in terms of discussions with our patients, that we really need to consider what we're going to do next as TAVR explant and redo TAVR outcomes, I'll be changing in the future as we get more and more experience. And as you could see from the Michigan data, you could improve your outcomes. And I'm sure Vino would also has data in terms of his group and in terms of improved mortality with experience. So TAVR are ever increasing implants, especially outside of guidelines. We need to do better. The data is clear in terms of the increased mortality currently with SAVR after TAVR. We need to focus and try to decide in terms of not only who do we put TAVRs on, but also what we do with SAVR. Who gets mechanical valve, who gets tissue valves. We need to have meticulous operative planning, improved standardization and techniques. With our patients, there's no right or wrong answers in terms of what valves we choose, when we do which technique. They are just action and consequences, and we need to be not only we need to be prepared for them, but the patients need to understand these issues. This is a rapid increasing diagnosis. There's going to be a significant number of these patients coming up, and we need to figure out how do we standardize these techniques and get this out there in terms of improving our outcomes. And patients are always going to prefer a catheter technique over surgery. It is up to us to educate our cardiologists and our patients in terms of what is the best strategies for them in the future. Thank you.
That's great, Danny. That's a great overview. I have a couple of questions for you, but I think we'll save those after Bart and Farouk give their talks. So next, we're going to have Bart talk to us, Miros talk to us about durability and valve suitability, insights from the 15 years of Perceval experience. I've learned a lot from Bart over the years on a lot of stuff, and he really represents the world's one of the world's largest experience in Perceval, and it's something that the Europeans have done a lot more than we have, Danny, here in the U.S. And so learning about this, really, I gain a lot of insight from Bart every time he gives a talk. So Bart, you want to take it away?
Absolutely, Vino. So thanks for the introduction. And I think I learned more from you than you from me, I think, to be honest. But anyway, thank you for saying that. It's a pleasure to talk a bit on durability and valve-in-valve suitability, because and this is a nice follow-up after Danny's talk. If you want to think about lifetime management, there are a few things that are important, and we know from literature, and these are some of my old papers. I mean, valve size is important to start off with. We know this is an old circulation paper where we see if you have a high gradient or patient prosthesis mismatch, you're going to have a much higher chance of having early degeneration in the tissue valve. Durability is also affected by the valve treatment. We know in the meantime, this is also one of my older papers where we compared a lot of older valves like the MitraFlow, the Toronto SPV, who had only glutaraldehyde and no further chemical treatment, and they really significantly degenerated faster in a clinical follow-up study. So these tissue treatments, they really play a role and they make sense, and I'll come back to that in further on the presentation. First of all, as Danny nicely stressed upon, the first operation, the first procedure is important. And if we go for SAVR then, and if it's a single AVR, I think we have to stress the importance of having minimal access, because when the patient's coming back for redo surgery, it will only facilitate the whole procedure. And if he's not coming back for surgery, then the valve at least has to be valve-in-valve friendly. And this is talking about visibility of the frame, flexibility, and no issues with coronary access, as mentioned in the previous talks as well. Now, do we have valves like that? Well, I think the industry is supporting us as surgeons with all kinds of innovations. And this is one example. This is the Perceval platform. It was originally Livanova, now it's Corsim. I was happy to perform the first in men now 17 years ago, together with the guys in Hanover and Paris. There's a wide bunch of implants worldwide, more than 100,000 in the meantime. There's a 2.0 version of the valve, because we started with Perceval. Now we have Perceval Plus, where there's an advanced tissue treatment present in the leaflets. I'll come back to that. And I just want to share a few slides, a few glimpses of our own experience, because since we were involved in the first in men, we had it in our fingers, we had it in the system here, And so in the meantime, it became a sort of our tissue valve of choice in a wide variety of patients. We like it because it's fast. It's a fast procedure. It gives you a short cross-clamp times, short CPP times. It opens up a lot of possibilities to minimal access, either mini thoracotomy, endoscopic, etc. And of course, it's also opening up a lot of possibilities towards a fast-track protocol, both in single AVR, as for example in AVR plus a single cabbage, or a simple double valve procedure. In our experience, I mean, if we talk Perceval, and this is 1,500 cases, 45% of them are single AVR. And if you look into single AVR, 75% of those are done minimal invasive. We were predominantly mini sternotomy, but we are moving into thoracotomy and endoscopic approaches with two of my young colleagues as we speak now. But of course, you can combine this valve with cabbage, with a mitral valve, plasty, even replacement, tricuspid ablation, myectomy, left atrial clip, and even ascending aorta replacement. So if you have the prosthesis in your fingers, if you have experience, then you can combine it with all a big bunch of stuff. This is a snapshot when we reached 1,100 patients. I have one PhD student doing nothing else than looking at the outcome of this whole cohort. In the meantime, we have submitted the full 1,500 patients data to AACTS. And it's really, this is a real world all-comers population. You see the age range is from 35, some exceptional congenital cases, up to the age of 87. Redo after TAVR sometimes. So we use it in a wide variety of patients. What is important for this presentation, because it's about long-term outcome, lifetime solution, durability, this is our total collection of mean and peak gradients across 1,100 patients with 15-year follow-up. And you see the stability of the peak and mean gradient across the board in a wide variety of patients. So quite that there's a big bunch of elderly patients there, but there's also some below 65, and you see the stability of the valves. And this is both Perceval for the majority and Perceval Plus for the last 5 years of our experience. Do we have degeneration? Yes, of course we have degeneration. When we look at SVD, we really use the VARC3 criteria, as we should do in a recent scientific investigation. So we look at increase in mean gradient of more than 20, or new aortic insufficiency more than 2 out of 4. And if you look into this collection of 1,100 patients, we have like 28 patients who meet this criteria. But you see, when you calculate the rate in percent per patient year, this is well below a 1% per patient year rate. So this is an acceptable result in a severe SVD rate for a tissue valve. And you know, some of these patients just meet the criteria for SVD. They sometimes don't have symptoms. They don't require reintervention yet. At this moment in follow-up, we had 9 cases who did have severe symptoms with severe SVD. And so they were all treated with TAVI valve-in-valve. But again, this is an acceptable number when you calculate the rate per patient year. Of course, if you have this kind of volume of patient with this kind of follow-up, you also will end up with some endocarditis cases, but also there is no difference between Perceval and other tissue valves or mechanical valves regarding the rate of endocarditis. As I told you, we just pulled the complete data on 1,500 patients. This is 17-year follow-up. In the meantime, I can tell you we are up to 14 cases of TAVI valve-in-valve. If you calculate the rate, it's still very acceptable. And all these TAVIs went very well. All these patients went home with a nice result. So we still are happy with the whole result of this prosthesis. In the meantime, we are not the only ones with more than 10 years follow-up. There's Teddy Fishline, there's the group for Marco Solinas, who has a huge experience in mini thoracotomy with this prosthesis. And you know, coming from these 3 published papers, I just pulled all the degenerated Percevals, so with the need for either redo SAVR, which is also possible. If you have to take out a Perceval, it's comparable to taking out one of the TAVI valves. It's even slightly simpler. But most of the patients, of course, get TAVI valve-in-valve if you have a degeneration. And so do you end up with like 56 patients who need a redo in 11,000 patient years of follow-up. So this is 0.6% per patient year need for redo is an acceptable result. And this is still a mix of Perceval and Perceval Plus. So I assume with Perceval Plus, with the new tissue treatment, it will only become better. Important to say, because this is also important in the lifetime management, if you have a degeneration of a Perceval, my cardiologists say is the easiest TAVI valve-in-valve they do, because, okay, number one, the visibility of the frame, it's nicely visible, you have all the landmarks available, and you have still an even expansion possible up to 2.5 millimeter. Important to notice also is that in this 1500 Percevals, I never saw a cusp rupture. So unlike what you saw in, for example, in the trifecta, or for example, in the freestyle, where you can have a degeneration with a cusp tear and a massive AR and a patient sometimes in pulmonary edema, we never see this. This is a typical stenotic failure. They fail in stenosis, so these patients are more stable and you can plan the reintervention. You see this is for all the sizes, small to extra large, the true inner diameter and the expandability up to 2.5 millimeter that is still possible in the nitinol frame. Because of the specific design of the valve and because of the presence of these sinusoidal struts, you always have a safe valve to coronary distance. So there is a very low risk of having coronary artery obstruction. I never had one. We did 14 now in the meantime. Okay, it's still limited, but we never had an issue with the coronaries. And we also never had an issue of sinus sequestration, because, you know, here is the sinotubular junction and the top of the leaflet is only halfway there. So there's never an issue of having this sinus sequestered during the valve-in-valve. There's a few tips and tricks. If you are using Medtronic, you align the inflow of the valve to the inflow of the Perceval. Very easy, very good, nicely visible. If you are a Sapien user, you put the top of the Sapien, you aim it at the top of the commissural struts of the Perceval, which are always nicely visible. And then because of the foreshortening, it will come nicely into place. Here's some videos. This is a degenerated Perceval, like 7 or 8 years after the implantation, and there's a Medtronic valve going in. There was a little under expansion here, but we did the secondary ballooning, and then there was a nice alignment with a nice hemodynamic result. And this is another example where we put a Sapien in, and you see the Sapien goes in a little bit deeper, aiming at the top of the commissural struts, but then because of the foreshortening, it nicely aligns the inflow, and so we'd also had a good result there. So this is a table. When we had 9 cases, you see the 9 cases, they all failed in stenotic SVD, so with high gradients. And then we were able to put in either Sapien or Evolut, majority is Sapien. Important to notice, we had one small. So for example, also in the small aortic root, you put a small Perceval, but if you have a degeneration, the patient lives long, you still have the possibility of putting a Sapien 23 in there, and look at the discharge gradient, 17/8 after TAVI valve-in-valve. There was one patient with a slightly elevated gradient. We were not happy with this, but it came down during the further follow-up. So the patient is doing well now. And as I mentioned, in the meantime, we have 14 of these cases with a very similar result. For those of you who are interested, we pooled all these technical tips and tricks into a short paper written by one of the cardiologists, gathering all our data on doing TAVI valve-in-valve inside Perceval. Of course, and this is the last part of my presentation, again, thanks to the industry, we have an evolution in tissue treatments, because, you know, they are important. We are coming from glutaraldehyde only, like the MitraFlow, like the Toronto SPV. We went into aldehyde detoxification, and now we really have this multi-level, multi-mode treatments with reduction of phospholipids, enhanced aldehyde detoxification, and no more toxic aldehydes in the storage solution. If you look at this, and if you compare this across the industry out there, you see the MitraFlow, for example, had none of these 3 elements, but slowly, gradually, the industry is moving towards this. And for example, we now have Inspiris Resilia and Perceval Plus with a free treatment, who have all of these layers of treatment. And I think this is important to avoid calcification and to prolong the longevity of the valve. This is a small young animal subcutaneous study that we did to check the efficacy of the anti-calcification. You see in control animals, control tissue, you have massive calcification with a huge amount of calcium. This is a piece of Resilia. These are two pieces of free treatment, and they are quite equally effective. So they are equally effective in this small subcutaneous rat model to avoid calcification. So it's promising for the future. And we have Perceval Plus now. I have 500 patients with a 5-year follow-up. We put the data for EACTS, and I can say it's a promising result. So in conclusion, yes, we have young patients. We have patients with long life expectancy. If you want to put push tissue valves, the sizing is important. The tissue treatment is important. Valve involves suitability, and you need to be able to do minimal access. And I think Perceval is one of the examples who offers all of the above. There's long-term data available, and it's growing year by year. So I'm looking forward to further follow-up of this prosthesis. Thank you.
Bart, that was an excellent review. I also have some questions for you. So next, Farouk is going to talk to us about the mastering the art of surgery redo tips and tricks. And hopefully he'll finish up in the next 10 minutes or so. And so we'll have about 8 minutes for questions. Thanks.
Thank you very much. Good afternoon. I'm trying to share my presentation. Okay. Is it visible? Hello?
Yes, it is. Thank you.
Okay. Thank you very much. So,
you mind, Farouk, you mind moving the middle bar up to the very top? It says app Zoom US is sharing your screen. Can you move that to the top or hide so that we can see? Just hit the word hide there. Yeah.
Okay, done. Okay.
Yeah, great.
Thank you very much. Thank you. So the management of aortic valve disease, particularly in patients with complex clinical scenarios, remains a significant challenge in modern cardiac surgery. Advances in valve replacement technologies have paved the way for innovative solutions aimed at improving outcomes while minimizing surgical burden. The Perceval sutureless valve represents a groundbreaking innovation in this field, combining a state-of-the-art design with a minimally invasive implantation technique. It offers unique advantages for high-risk patients and those undergoing complex procedures, such as redo surgeries, infective endocarditis, combined valve surgery, or operation involving small aortic roots. So in this presentation, I will try to explore the role of the Perceval valve in addressing these challenges, focusing on its clinical efficacy, surgical techniques, and real-world application in complex cases. By the end, we aim to provide a comprehensive understanding of how this technology is shaping the future of valve replacement surgery. As we see, we have a lot of data regarding the use of sutureless valve in complex cases. So let's merge in some of our critical scenarios and critical cases we saw in our experience. So this is a very critical lady, 65 years old, who came with an ejection fraction of 35% and with infective endocarditis. She was operating before and replaced her aortic valve was a kind of tissue valve that we did not know exactly what was the nature of that valve. This is the preoperative echo. You can see the lady was having severe mitral regurg and severe aortic regurg and stenosis. You can see flickering masses in the aortic position. Intraoperatively, we had a kind of surprise because we found a really porcelain aorta, and we realized that this patient had a homograft implantation before. So in a very critical patient with a lot of comorbidities, we thought that the best strategy for her surgery would be, if possible, to replace this homograph or this aortic valve with a sutureless valve to avoid doing a major surgery. So as you can see, the valve is completely destroyed from the infection. A lot of debris. This red dot is the left main. So we repaired her mitral valve with the mini band, and after that we resected the aortic leaflets from the homograft, cleaned all the tissues, and in no time we implanted a sutureless valve. This is the end result. Mean gradient through the mitral valve was 3 millimeters of mercury, and the mean gradient through the aortic valve was 3 millimeters of mercury. The second case, it's a patient that underwent aortic valve replacement with a sutureless valve 4 years before coming to our center with an infective endocarditis. As you can appreciate, the aorta is full of vegetations, which is removed, and after cleaning of the aortic root, we started removing the Perceval. And this video is to show you how easy it is to remove a Perceval implanted 5 years before. As you can see with the forceps, we just do a kind of peeling of the stent of this valve. If you want to compare it with the TAVR procedure, you can see that it's extremely easy to be done. And actually, the whole process took us 1 minute and 20 seconds to remove the valve. And we end up with a perfect aortic annulus and perfect ascending aorta. So no damage was done in the ascending aorta and in the aortic annulus. This is a Perceval implanted 5 years ago and attacked by the infective endocarditis. You can see the damage on the valve. Leaflets, as mentioned by Dr. Bart, is the last attacked by the infective endocarditis process. And here you see another Perceval was implanted in the same patient. Another case, a female with previous non-open heart surgery for congenital problem, presented to our center, and this was the preoperative echo. Aortic valve was showing aortic regurg and a high gradient, mean gradient of 68 through the aortic valve. This is the intraoperative view of that patient. You can see the old aortotomy here. And the small aortic valve, it's a bicuspid valve and very small annulus. So even here we thought that implanting a sutureless valve will be a great opportunity. We put a small sutureless valve in this patient. This is the post-operative echo, no paravalvular leak. The valve was functioning well. And this is the transaortic gradient of 7 millimeters of mercury, so low gradient. Another case was a severe LV dysfunction, 15% ejection fraction, patient with severe aortic regurg, severe mitral regurg, and severe aortic mitral stenosis, severe tricuspid regurg, and an atrial fibrillation. We replaced the mitral valve with the tissue valve, and this is the sutureless valve implanted in position, functioning well. Mean gradient through the aortic valve was 3 millimeters of mercury, and this is a mean gradient through the LVOT. Another case, a 70 years old male, previous Perceval implanted 7 years ago, admitted with acute coronary syndrome, coronary angio done, and showed the severe LAD lesion and severe OM lesion. The patient went for CABG ×2, Lima to LAD. You can appreciate the Lima to the LAD and the Perceval in position. And this is the Lima, which was done as a free graft to the OM. You see that we did our proximal anastomosis a little bit high in the ascending aorta. and there was no problem at all with the presence of the sutureless valve. This is a very, very interesting case of para-aortic abscess. As you see, the native aortic valve is completely damaged by the infective endocarditis process. We have a lot of aortic cavities and vegetations inside the aortic root, as you can see. This is a vision.
We have dropped off. I don't see him anymore. So maybe I can start with some discussions. Thank you guys for the great presentations. So Danny, you know, from a surgeon point of view, we have somewhat limited surgeons. We have 6 surgeons here, and we've limited who's going to do what procedure. So at your hospital, or Bart, at your hospital, is every surgeon in the practice doing TAVR explant, or is that something that you've kind of limited so that we can gain some expertise so that our outcomes are overall better? How have you dealt with that?
So, you know, it's always hard to tell surgeons, you know, we should limit certain procedures. But we've moved to that model for not just that kind of procedure, but for a lot of different things. So for mitral, we have a mitral team, we have an aortic team, you know, we have a heart failure team, and we didn't carve out a TAVR explant, but it's falling on the aortic, you know, the aortic team. In terms of the where the cases are being referred, so it was an easy discussion to have. And those who are getting TAVR explants tend to be in that group. I do some, even though I'm not in that group, but I've had experience, significant experience. And our junior surgeons calls one of our senior surgeons when they get one, so that we could build that experience a little bit broader. We have 6 centers, soon a 7th center, so it's kind of hard to always have these cases sent to the main house. So we're building our expertise by partnering experienced surgeons with less experienced surgeons. But this is truly a procedure that not everyone should be doing, because as you saw, the median number is 1. So at this rate, it's going to take us 20 years to be able to build a volume for everyone to be able to do it.
No, I agree. Bart, how are you doing it in Europe?
I think if the case is sort of elective or not really urgent, I think you better pull to some of the either senior or guys who have experience explanting these things. But of course, you know, sometimes it's like endocarditis, or it's a malfunctioning TAVI and it's semi-urgent. So all of the staff members here have taken one out in the meantime. But I agree completely. If it's like a sort of semi-elective or elective case, it's better to pull to someone with experience.
I think that you're absolutely right. The other question I have, Danny, are you doing any of these explants robotically, or is that something that you've stayed away from?
I've stayed away. I think right now, our onus is to have the best outcome possible, and you know, so we just need to get our numbers in an area where when we do it open, our mortality looks more into the 3 to 6% range in general, and that we are comfortable knowing which patients may need more than just an explant and an AVR. Once we get there, we could approach it robotically. I've done the mini invasively through a right anterior, so those are doable. But robotically, I don't think for me, I don't think it's the right time to approach this.
Yeah, you know, I haven't done it. I actually have not even done them as a mini. I've done them as a sternotomy, because, and for me, it's just getting in and out without having to worry about it. And so I have not done that necessarily. I've done them through sternotomies, and knock on wood, you know, I haven't had a single 30-day mortality. And so I think these patients are higher risk, and I want to get in and out. You never know what you're going to find. So I've not even done a minimally invasive, and maybe that's a reflection, you know, of, my success over at least 30 days. It's hard to follow these patients long term. Bart, how about you?
Sorry, say again. So I was
Have you done a lot of these cases? You're not doing robots, but are you doing TAVR explants?
Minimal. We shifted the mini. We use the mini upper sternotomy for a big bunch of cases. It's also for the roots, also for the aortic arch, and also for the redos. Yes. But we, although we are invading now in thoracotomy and endoscopy, not for the redos yet.
Okay. Yeah. So, one of the things that, Bart, as far as taking out Percevals, I have not had to take out a Perceval. How is that? Do you compare that to taking out a Sapien? Do you do that comparing to taking out a core valve? What's kind of in your mind? How
It's
you?
I've did only the redos are either for endocarditis. Sometimes it's easy because the valve is
That's easy.
half loose. For pure SVD, I do it like you. You either with a knife or with a coagulation on a low volume. You just first free up the outflow ring from the aortic wall. If it's touching there, you have some mild ingrowth or overgrowth, and then it's a nitinol frame, so it's comparable to the self-expanding valves.
Yeah.
But you can squeeze it. You can squeeze it sometimes with a tourniquet, yes or no, and then you work your way to the annulus level. And you do the same, either with a knife or with the coagulation, and you burn on top of the frame or you cut on top of the frame. And you can, if you take a few minutes time, you can take it out without damaging the root. So we took them
Yeah.
out, and we do a Perceval again. So it's perfectly possible.
Yeah.
So
Yeah, no, that's great.
yeah.
And would you say that most of your Perceval implants are for isolated surgery, or is it with concomitant or
It's
well?
50-50. It's like 45% is single AVR, 55% is concomitant. The majority there is cabbage, but you can do mitral valvoplasty or whatever. I mean, if the patient is above 65, above 70, and there's combined surgery, this is our valve of choice because it saves you like 20, 25
Yeah.
minutes easily.
No, I would say a lot of my AVRs that I do now, isolated AVRs, are either bicuspid valves or they are AR valves, where there is no TAVR option for now, anyway, for those, even though that's coming down the pike also. And it seems like to me that, Bart, that it would be more, taking the Perceval out would be more, quite honestly, easier than a surgical valve, because you don't have 15 to 18 stitches to take out. You don't have all the pledgets underneath the valve to take out and things like that. I've gone away from pledgeted stitches for my AVRs and just go to figure of 8 non-pledgeted stitches. But it seems like to me it would be easier than a surgical valve, quite honestly, right? Because you don't have to go cutting out 18 core knots and trying to make sure that you get all the pledgets out. Is that your experience?
Well, that's right. I mean, the experience is limited in the surgical
Yeah,
explantation,
right.
of course, but the thing is, the inflow ring is certainly easier because there's no suture, there's no pledget. The outflow ring, if you have a narrow sinotubular junction and the outflow ring is really incorporated into the aortic wall, you need to take some time and some caution not to damage the aorta.
Yeah.
But sometimes it's free. There's a distance between the outflow ring and the aorta. So
I would imagine just getting that outflow ring would be the most important, like a
absolutely.
self-expanding valve.
Absolutely.
Yeah. So, and I also think that a TAVR in Perceval would be somewhat easier because you don't have to worry about a cracking a valve and things like that. Last week I did 2 TAVRs and SAVRs, and one was a 25, one was a 21. And the 21, we really had to pace 3 times. We had to use a sapien valve. We really had to take the atmosphere on the syringe to 15 psi just to crack it. So those aren't easy things to do down the road. And I think that Perceval may have that advantage of doing that as far as not having to do the cracking component of it.
Absolutely.
Yeah.
Vito, can I have a question for you? Because you
Yeah.
mentioned something on increase in mechanical valves. How do you, for example, a mechanical valve in aortic position, what is your anticoagulation that you there's a lot of self-management, INR, self-management. Is there, what level are you anticoagulating? Just curious.
Yes. That's a good question. I always start off with a goal of 2.5 to 3 for the first couple of months, and then I let them drift down to about 2.
Okay.
I don't say 1.5 to 2, because if you tell people 1.5, that means that 30-40% of the time it's going to be 1.1 and it's going to be below 1.5. So I tell them at 2 after that kind of 90-day period of 2.5 to 3. I just want good endothelialization to do that. There's not great data for this. I mean, there's only one trial that the guys have done, at least in the Onyx valve. But I've been very happy with mechanical valves in these younger patients. I think we have to think about that across the board for patients that are younger. So I know it's 8:01. Let me look here on Q&A. It looks like there's a couple of questions. Are there aortic root enlargement techniques that are more suitable for TAV and TAV than others? What has been your experience with TAV and TAV in patients who've had a Bo-Yang aortic root enlargement? So maybe I'll answer that in the saying that, for my, I haven't done a lot of Bo-Yang technique. Personally, I've done a NICS procedure with a very large U-site patch, and that usually gives me a 2-size upsize. And for me, the way I don't tilt the valve a ton, and so that I haven't had to do a TAV and TAV, but the way I get some echoes and CTs on my patients, I haven't had to. It hasn't been an issue theoretically, but I haven't had to do a personal TAVR in patients with previous aortic root enlargements. Bart or Danny, have you had to do that?
No, not too many, and I don't yeah, as you said, I don't use the reverse Y Bo-Yang technique a lot. Most of the time you could just do a big U patch and get a 27 in most patients without having to do a more extensive enlargement. But similar to you, no real differences.
How about Bart? Or what are you doing the inverted Y Bo-Yang incision, or are you doing something else?
No, absolutely done a few cases of that. And I mean, regarding to the question, I don't think whenever if there's a root enlargement done and you put in a sutured stented valve, yeah, after a while it doesn't matter whether it was root enlargement. This patient just received a bigger stented valve, and so the TAVI valve will be easier. What we also did is, given our experience with Perceval, we combined root enlargement with Perceval. It takes a little bit of attention to position the Perceval in order not that it doesn't flip out or migrate, but it's possible as well. So, but I think root enlargement is important if you have a young patient, small root, and long life expectancy, and you expect to have valve. I think it's better to put a significantly sized valve so the re-intervention is easier.
Yeah, agreed. Another question is, TAVI has lower mean gradients than SAVR. How much of this finding is due to higher rates of PVL with TAVI than SAVR? I don't think that has a huge component. Maybe that was something historic that were issues, but I would say that the moderate severe PVL rate now is under 1 to 2% in almost all of the contemporary studies. And so that I don't think has a lot to do with that necessarily. Any Bart or Danny, any thoughts on that?
No, I agree. I mean, it's significantly lower now. I don't think it's a major issue anymore.
I think mild is, and I think we don't know. We'll have to see where 10 years, so far, 5 years, mild hasn't made a big impact, but we'll see what carries out long term.
Yeah.
So here's SAVR in TAVR. Yes, I imagine that's explant. We covered that a little bit from the upper mini thoracotomies and stuff. So I think that we're 5 minutes over. I'm sorry, but any other questions, Danny or Bart, that you may have for either of us?
A question for you, is what's your story and what do you tell the patients who are 55 to 65 now when you see in the office that say I want a TAVR?
Yeah, look, I tell a lot of these patients, we have a special computer program, DASI simulation, that we use. And I first talked to them about tissue versus mechanical. And at that age, I'll tell them that mechanical is what the guidelines recommend. I think we'll give them that one-time shot, of course, if they don't have endocarditis. And in my hands, I don't put pledgets underneath. The chance of having that mound of pledgets underneath the mechanical valve, which all of us have seen in redos, should not be an issue in my hands. And so for that, I tell them that a mechanical valve will give them that one shot. I get a CT on every single patient, so I tell them that they're going to need a root enlargement versus a root replacement, and so my recommendation in those patients is a transcatheter valve. If they absolutely insist on a tissue valve and not a mechanical valve, and they're safely able to be done with a TAVR, then I don't have a problem with it. Even though, because in my hands, a redo TAVR is very similar to a redo SAVR. I can take it out. My cross-con time is usually under 45 to 50 minutes with redos. And so in my hands, that's exactly what I tell them. But I get a CT on every one of my AS patients, period, AR patients, to really give them that best kind of informed decision. But it's really about tissue versus mechanical, more so than it is SAVR versus TAVR for me. So. Okay, so maybe on that note, I know we're over. We apologize to Corsim. We thank you very much. I think this has been great. We had just great interaction at the Heart Valve Society meeting in Cairo recently, and I know that and here same way. I'm sorry that Farouk's internet was a little unstable, and so we missed him. But we really appreciate the opportunity to talk about this very important topic, and everybody should hopefully have a great day and evening for you, Bart.
Thank you, Vino.
Thank you.
Always a
Thanks.
pleasure. Thank you.
Thanks,
Bye.
Danny.
Bye.